Welcome to the Golf Fitness Bomb Squad podcast with Chris Finn, a production of P4S Golf. Welcome back to the Golf Fitness Bomb Squad. My name is Chris Finn, and I am your host. And today we're going to talk about a very common thing that golfers deal with, particularly the aging population. And by aging, you could be 45, depending on what the orthopedic history that you've lived has been. But hip and knee replacements, we're going to talk a lot about today, and the impact that they can have on your golf game, both wanted and unwanted, as well as we're going to be diving into kind of common misconceptions, pitfalls to look out for, common things that are in the medical world right now that are actually counterproductive for you as the consumer, as the person having the joint replacement. So a lot of kind of false beliefs and actually some bad medical practices that are out there just to look out for. And unfortunately, they happen more than you know and would expect. And also to talk about just the healthcare system in general that you're probably interacting with, and help you to best navigate it so you get back to the golf course as quick as possible and avoid a lot of the common pitfalls that unfortunately we see here at P4S Golf too late. We get people after they've should have been playing for 6 months already, and they're still not back because they did a lot of what we're going to talk about, unfortunately, and ran into a lot of these roadblocks and just didn't know any better. So let's start by just talking just quickly. If you don't know what a joint replacement is, so hip replacement or knee replacement, those are going to be the focuses today. We'll do another episode at some point talking about shoulder and other general, specific replacements, but knee and hip are definitely the two most common replacements that we have in the U.S. And just in the world, with the start of the adoption of like 3D printing and those sorts of things, you'll start to see other joint and bone replacements. I actually already had a golfer who had a talus 3D printed replaced into her foot, which is pretty wild. But it's a big bone in your foot, for those of you who don't know. It was pretty cool. I think she was like one of the first 20 people to have that done. But I digress. So a joint replacement is basically, so if you think about your knee, there's the bone that comes up, your shin bone or your tibia from the bottom. You have your femur on the top. There's kind of two, the ends of both of those bones. And basically in a joint replacement, in the middle, there's obviously a meniscus, which is like think of a pad. And then you have your kneecap on the front. So in a joint replacement, there's a couple different types. You can have a full joint replacement, which means they basically saw off the bottom of the top bone. They saw off the top of the bottom bone. They saw off the back of the patella, and they basically put prosthetics, kind of caps on everything. So they kind of, it's pretty violent. There's saws and and hammering, but to make sure that everything is into the bone. Then the bone eventually grows around it, and it's secure, hopefully, assuming that you have good bone density and whatnot. But basically, then what that means is then the connections of the femur, the top leg bone, and the tibia or the bottom leg bone, and the back of the patella are all prosthetic. There are no any jagged edges or anything that you had there are now gone. The meniscus is taken out, and now there's a padding that's basically synthetic that's there. It's not human material anymore. And so at that point, that joint is now fully replaced. It is a full, no reason why any structural issues should occur. Now, asterisk, assuming they sized it correctly and they put in the right, and that the surgeon did a good job, there should be nothing structurally wrong. In the hip, a full hip replacement is they basically take, basically the ball, the top of the femur, they shave it off, replace that. Then the inside, the socket, same thing. They replace the entire joint. You can have what's called like partial or hemi replacements, where they do maybe only one side, or maybe one side could be like left or right. They could do just top or bottom. So you can have different varying degrees of replacements, and then there's obviously different approaches. So the approach really will impact how the early rehab, meaning like the first 4 to 6 weeks, is done. And obviously, I would research, if you are having a joint replacement, or if you did, research what type of approach the surgeon that you used or are thinking of using will use, possible pitfalls, possible pros and cons of those as well. So hopefully that gives you just a general idea of what the joint replacement is. So basically, the first thing that I wanted to talk about is the idea that most people can think about getting back to playing is that I had my joint replaced. I don't have good, rotary mobility in my hip. And particularly in the lower body, right? I don't have good rotary mobility in my hip. That's normal because I had a joint replacement. Totally false, and couldn't be more wrong. Couldn't be more stupid to say that or to be told that, right? The fact that you've dropped 5 figures to get a new joint, you should have structurally, there's no reason why you should not have full range of motion, particularly 12 weeks of a hip replacement, ideally earlier than that. And the knee replacement, you should be looking at a full 120 degrees of knee bend. There's obviously no reason why you shouldn't have full hip mobility. Honestly, if you had your knee replaced, that's even more reason to have full hip mobility to protect that newly replaced joint, so there's not additional stress on it that shouldn't be there, right? So the number one thing that people need to understand, and I hope that you understand listening to this, is if you've had your hip replaced or you're thinking about having your hip replaced, your expectation should be that at 12 weeks you are getting a full 40 degrees of internal rotation in that hip. Now, depending on your approach, they likely will limit your internal rotation initially, but that's all, like I said, research which approach you have. But by 12 weeks, everything structurally should be healed, barring any complications, and you should be able to get that full 45 degrees, which is what we need in order to get through the golf ball, particularly on that lead side, as well as to create a full turn into the trail side. So I guess that's myth number one, or false belief number one, that I want to dispel, is that your expectation should be full range of motion. And what that is 120 degrees in the knee bend. So flexion, you should be able to get your knee totally straight. That is the first thing that you should be able to do. And that's within the first 2 weeks. The quicker you can get it straight, the quicker your rehab is going to be. And so that's kind of it from a mobility perspective. I just wanted to ram home normal hip mobility is expected for both of those replacements, and knee mobility should be 0 or even hyperextended, so negative, a negative number, so it'd be like negative 10 or whatever, all the way to 120. Those would be kind of the goals. Now, there are some caveats if you're hypermobile, if you got other stuff going on, but generally speaking, those would be the expectations that you should hold your providers to when you come out of that surgery. Now, so let's fast forward. Let's say you got all that mobility. You're now hip replacements 12 weeks. A lot of the doctors will say you can be back playing golf in 3 months. I would say I agree, as long as ... We'll get into the kind of considerations that would have to be met in order for me to be comfortable with you recommending you go back and play. Knee replacements generally take a little bit longer. You're probably more in that 4 to 6 month range. They tend to rehab a bit slower, but by 6 months you should be good. Okay. And obviously the predictors of speed of recovery in the early days are getting back muscle contraction in your quad, getting the knee totally straight, and then the bend will come. The most important thing is that you get the knee totally straight so you can return to walking normally. For the hip, the most important things are starting. Same idea. When you have surgery, your muscles, especially in those first couple of days, will kind of be a little laggard in responding. You may have a hard time even turning them on. So you kind of have to start from the ground level of can you get the muscles to actually engage and turn on, and then we can progress from there. So let's fast forward. So we kind of move out of the early rehab phase. Let's fast forward into kind of what I would call mid to late rehab, which it means your pain is pretty well controlled. You're walking around kind of daily functioning pretty well. And your doctor probably has said, hey, you can chip and putt. I think unfortunately the medical world's, the orthopedic surgeon is very, at least old school ones, are very time-based and not kind of qualification-based or metric-based, merit-based, right? So they'll say, hey, at X amount of weeks, you can do this, as opposed to saying, hey, as long as it's been X amount of weeks and you can do X, Y, you can demonstrate the ability or the capability to do, 1, 2, 3, 4, then we can go ahead and do this. Then you're cleared for this activity. So if you're looking at just time-based metrics, that's a terrible way to do it. You need to have these other kind of considerations in your mind. And that's a lot of times where the physical therapist, if they're good, that's where they will a lot of times bring that into play. So just to give you a mental framework to think about your rehabilitation surgical team, the orthopedic surgeon to me has always been like the builder or the construction guy, right? And having just built a big building, the analogy held. Right. All they care about is, does the structure go up? Are the steel beams up? Are they going to fall down? Or are they going to be stable, right? And so that's basically what an ortho surgeon is they're trying to see, hey, I want to make sure the structure is good, the joint is good, and that it's going to hold. And if that's good, they kind of move on and they pass it along. And then, unfortunately, then you only see residents. And this is unfortunately part of the system that it's not the orthopedic surgeon's fault necessarily. It's part of the system that they're in, where they get the hospitals and the insurance companies pay a lot for surgeries. They don't necessarily pay a lot for clinical visits. So you'll see the physician assistant or the interns or the residents. It's rare that you'll see the actual surgeon very often, right? Because they're more valuable to the system doing actual surgeries than just signing off notes later on in the day, right? So, and if you do get to see the surgeon, good luck if you see him for more than 5 minutes, right? So they're kind of the structural construction workers, right? And to them, the project is done when the steel beams stay up unfortunately for a lot of people, right? And this is not across the board. There are some phenomenal surgeons out there who actually care about the rehab process and will follow you along. I would encourage you to find these types of surgeons when you're interviewing to have things done. For those of you who have already had the surgery, I'm sure you can relate to the situation I'm describing. Now, then you will go to a physical therapist. So now, more than likely with a joint replacement, you're not going to a cash-based therapy place because you've just blown your entire deductible on the surgery. So it would make sense fiscally to go to an insurance-based therapist because it's already free, right? Because you met your deductible. So I just want to make sure you understand the framework that these therapists are working in, and that is the insurance companies dictate how much they get reimbursed, which a lot of times is less than, it's maybe $60 to $100, per patient, right? And a therapist is generally making $40 to $50 an hour. So there's not a lot of margin to play with, particularly if it's $60. So some insurance companies will even just do a $60 flat fee for no matter how long you see people, right? So that's why in the insurance world, as a therapist, more than likely the therapist is seeing more than one patient in an hour. They may have multiple patients at the same time. And as the patient, you see the therapist to do your initial evaluation. They have to see you every 30 days to do a reassessment. So it'll be magical how on the 30th day they spend a whole session with you. Other than that, you're probably with an assistant, an aide, somebody who costs less money to watch, just kind of follow you through your exercises that are just pretty generic. And then you're kind of progress, along that way. And every 30 days you check with a therapist. So it's not necessarily their fault. It's the system of insurance. They don't pay a lot. So in order to be profitable and stay open and pay their people, they have to see, when I worked in the insurance world, I saw 22 people in a day. I'm a pretty good therapist. It's tough to be a great therapist in that setting. I mean, shoot, even be a good therapist. So that is the constraint that you're dealing with. You're also dealing with the fact their goal and what insurance will pay for the therapist is to get you pain-free and walking and just functional in everyday life, right? They're not allowed, the insurance company will not allow them to charge them to get you back into golf and playing at a high level. So I think that's where you need to understand the role of the insurance-based therapist in this process. Is their job, and they're very good at it, is getting you pain-free, getting swelling out, getting you back to functioning in a your day-to-day life and feeling pretty good, right? So now they are what I would call they kind of like put in all the appliances and make it where the house is at least relatively comfortable to live in. It looks decent, right? They go in and make sure there's not any holes or cracks, and they work, and we'll obviously talk with the orthopedic surgeon, the guy who put up all the steel structures, if a beam is a little loose or something's just not seeming right structurally, right? So now the key is then you go to the late rehab. This is where insurance stops paying. And this is where then you got to think to yourself, well, how am I going to get back to playing the game of golf, right? And this is where we definitely, if you had a joint replacement or thinking about it, take the home assessment that we offer P4S Golf. It's, we'll put the link below in the podcast. If you're just listening, you want to check it out. It's par4success.com. You should find the home assessment there. But this is where you start to look at your hip rotation, your shoulder rotation, your trunk rotation, your neck rotation, all your rotary centers, and are they as good as humanly possible? In an ideal world, you're starting to look at this stuff like week 4. Like you're already working on these other areas and making sure mobility is not a problem whatsoever by the time, so that when you get to the end of like traditional rehab, and I'm doing air quotes here, right? Basically where insurance will stop paying for you, that there's no need, your mobility is great, you're ready to go from a mobility standpoint. Really, then the question becomes how strong you are, right? And remember we talked about at the beginning of this pod here, this episode. you should have full hip range of motion. There's no reason you shouldn't have full shoulder and all those other areas after hip and knee replacement. So you've got good mobility. So now we start talking strength. And this is where we know from getting back to playing just a general golf performance standpoint, vertical peak power production and upper body peak power production are massively important for producing club head speed and doing it the right way. So if you have mobility, then we need to make sure you have the strength in order to support the club head speed that A, you were swinging before surgery, and B, you want to swing after club surgery. If you do this correctly, guys, you should come out of surgery swinging faster and better and feeling better, obviously, because you have a new joint than prior to surgery. Having surgery and saying my game has gone downhill since I had my joint replaced because that's just what happens is bullshit. Like, that's totally false. That is not, that just doesn't work. That's wrong. I cannot say that enough times. That is wrong. That is wrong. That is wrong. If you've had a joint replacement, if you rehab correctly, you should come out stronger, better, and faster. The one thing that, so assuming you have the mobility, you have the strength, the last piece is getting you to actually trust the leg, right? And unfortunately, for a lot of you who've dealt with, who've had a joint knee or hip replacement, you've probably dealt with pain for a lot of rounds of golf, a lot of years prior to getting the joint replaced. And what that leads to is bad motor patterning, bad habits of movement, bad swing habits, right? So you develop all these compensations to deal with the pain. Well, now the source of the pain is gone. So now you have good mobility, you have good strength. Now we have to teach your brain that it's okay to move like an athlete again. It's okay to move through the golf ball in these more efficient ways. And that's where doing some transfer training, which is basically, using implements other than a golf club to help you start to figure out, well, I guess that's not totally true. Transfer training, we can also use a golf club, but you can use golf club and non-golf club elements, such as a medicine ball or cables or bands. You can use other training aids, heavy sticks, light sticks. You can use actual golf clubs too. But that's where then working with somebody, your strength coach or a physio. This is usually has to happen in the cash-based world. Not usually. This always has to happen in the cash-based world. This is where we live, right? Is getting people where you get kind of dropped off in this no man's land of insurance says I'm good to go, but I'm not where I want to be. I can't go walk 18 holes and play golf the way I want to play, right? So this is where we step in. This is what we specialize in, is picking people up out of that rehab phase of, hey, you're functional, but I'm not where I want to be, and getting you to that point. And a lot of times bringing you beyond that. And so I think that's the other false belief people have, is they don't believe how far that they can go. It's amazing how far you guys can go if you're doing the right stuff and you're assessing and you're not guessing. It's really, really neat. So this is the phase. If we think of your rehab process, just to summarize here, you have obviously the surgical procedure, which think of that as if you're building a building, the ortho surgeon is the guy who puts up the structural beams and makes sure they're not going to fall down and kill someone. Okay. That's the joint is replaced. Then you go and you get the insurance-based therapist, your immediate rehab. That is, they're putting in the sink and the faucets and the stove, right? They're putting in all those connections to start to make the home livable. Maybe not exactly how you want it, but it's livable, right? And then you got to go to that last stage of rehab. And that to me is where the interior decorator who kind of puts your custom touches in that you want to see. Maybe they do some added like upgrades or whatever you want in the house to get it to exactly how you want it to be. That is golf, right? So living is just a human, right? That insurance base gets you to be back to being a functioning human. To be a golfer, you got to get the interior decorated. You want to upgrade the faucets or the whatever it may be, the floors, right? That is where that last phase of rehab comes in, and that's where you start to look at, this is where we'll have guys and girls who've had the rehab or had the replacement and then done the insurance base. We'll have them come in and swing and look and say, hey man, you're producing your ground reaction forces like after you hit the golf ball, right? And that a lot of times, if you look at a lot of the research we've done, post joint replacement is you will still follow the same patterns you had pre-joint replacement. We've had a number of people who we knew we had data on them pre-joint replacement, and then we obviously get them again after joint replacement. And there's not a lot of change necessarily. Now, once you train and you have the right drills to do, those changes happen pretty quickly, especially if you've had your rotational mobility and your strength is where needs to be. It's a relatively easy change to get there. And it's so cool to see the light bulbs go off in people's heads. They're like, holy cow, I never thought I'd do this again. So it is a process. I do want to, doesn't happen, overnight, but it is something that is totally doable if you know the right things to do and you know how to do them, and you have someone to kind of guide you along the way there. I'm trying to think. I think that's the gist of kind of the big things that I wanted you guys to know and understand. The last piece would just be prehab. So a lot of people ask me, hey, I know I'm having a joint replacement. What do I do beforehand to assure that I'm better afterwards? And I would say you can always work on all your rotary centers, work on them as much as possible. You can do strength work as much as you can tolerate. I think the thing is when you're prehabbing for a joint replacement, you're not going to make the joint any worse, and you're just going to get it taken out anyway. So who cares? So whatever you can tolerate, go after it. Get stronger, get it as mobile as you possibly can, and the better shape you are going into the actual procedure and the replacement, it's well documented. It's a much faster recovery, along the way. So if you have any questions at all on this, definitely reach out, drop us a line, any of the social media channels, or just shoot us a note. But definitely grab the assessment if you're looking to have the joint replaced. If you've had it replaced and you're just curious where you're at, I would definitely grab that assessment too. That's a great litmus test to see how you're doing. But please, I think the number one message is don't be discouraged. If you feel like you got left in no man's land, that's just, you're not alone. That's unfortunately the system that we live in the healthcare system here. But the good news is there are solutions to help you get back to playing golf better. And I mean, shoot, even just back to where you were. Unfortunately, some people come out of surgery worse than they were. But definitely most cases we're able to get people even not just back to where they were, but significantly better. So we're not alone. There's other people like us out there, but if you need help, please let us know. And please, hopefully this gives you some hope that and confidence that, longevity in the game, with or after a joint replacement is not just like can happen. It should happen. This is definitely something that should occur if you have the right information, which now you should have. You likely have more than 95% of the population after just listening to the last 20 minutes. So anyway, thanks for hanging out for a little longer episode on the solo today. But I really wanted to dive into this and cover it. There was a lot of topics here. If you do have any other questions, obviously, always let us know. But hopefully we diffused a few ticking time bombs. You may have done rehab the wrong way. And we look forward to catching you on the next episode.